This is going to be topic 51.2, environmental cold emergencies.
Key concepts. After completion of this chapter, you'll understand pathophysiology of hypothermia, hypothermia as a disorder, assessment of the hypothermic patient, and treatment of the hypothermic patient. So winter brings about cold emergencies. Hypothermia occurs everywhere. Cold illnesses account for an average of 647 deaths annually, and over 50% occurring in the elderly patient. Paramedics will treat cold emergencies regardless of geographic location. Chief concerns: thermoneutral body temperature is between 97.7 and 99.5 degrees Fahrenheit. Metabolic reactions best occur at these temperatures. Extremes of temperature interfere with enzymatic reactions and retard metabolic processes. Heat loss, like evaporation, conduction, convection, and radiation. The forces are at odds with the body's need to maintain an internal core temperature. 65% of the body's heat is lost through simple radiation of the heat to the atmosphere. Wearing lathered clothing can help decrease this loss. And these are evaporation, which is sweat on the skin and then brings heat with it. Respirations, everybody can see your breath in the wintertime. Wind blowing over you, convection, you radiating, giving off heat, and then conduction if you sit on a cold rock. So all of these decrease your body's heat, or will cool you. Thermoregulation, the hypothalamus, helps us control body temperature and regulates heat production. Thermogenesis, process involves heat production, muscular contraction, shivering, which is rhythmic contractions of the muscle at a rate of about 20 contractions per second. Epinephrine, and more specifically adrenaline here, controls peripheral blood flow and can reduce blood flow to the skin, and also can increase glycogen metabolism. Epinephrine, in the case of shock or poor cardiac output, is one of the first defense mechanisms that is released for compensation. Hypothermia defined: hypothermia, suboptimal body temperature, incompatible with life, occurs along a continuum. Levels of core temperatures: mild hypothermia, body's core temperature drops below or between 89.6 degrees Fahrenheit and 95 degrees Fahrenheit. Moderate hypothermia, core temperature is between 82.4 and 89.6. Prolonged core temperatures below 82.4 is not compatible with life. Etiology of hypothermia: mostly unintentional, prolonged exposure to the cold while outdoors, prolonged entrapment such as a motor vehicle collision or building collapse, prolonged exposure to tepid water, so room temperature water, if you're floating in it, it's just pulling heat off of you. Urban hypothermia. People fall victim to hypothermia. This is pretty much talking about our urban outdoorsmen here. Not prepared, they don't have adequate coats, things like that. Extent of the problem: mild cases generally are unreported. Severe hypothermia has a higher mortality rate. Pathophysiology of hypothermia: the pulmonary system vasoconstricts in the pulmonary vascular. So all of the stuff in the pulmonary trunk essentially constricts up. You get a right to left shunt. Blood does not come into contact with the alveolar air or gas exchange, and this causes hypoxia or tissue hypoxia. Cardiovascular system: we can go into systole or non-cardiogenic pulmonary edema. And because of the increased pressures from the vascular constriction, we lose the fluid that once is where it was supposed to be because of adequate pressures, now can spill back over into areas that it shouldn't be, like the alveolar sac. Cold diuresis: excessive urination due to decreased temperatures. Blood shunting towards the core causes the kidneys to engorge, which increases urine output. Local cold injuries: examples of this is going to be frostbite, freezing of the tissue. Superficial is considered frostnip, generally resolves spontaneously whenever rewarmed. Deep frostbite would be full thickness. Important to get treatment as soon as possible. As soon as it rewarms, there's going to be tons of tissue damage with deep frozen or the deep frostbite. Treatment: remove from the environment, remove wet and constricted clothing, apply dry dressing. In extremity injuries and immersion, Immerse affected limb. Affected extremity is gradually immersed in tepid water, and this is something we generally don't initiate in the back of the ambulance. And then splinting, used if immersion rewarming is not available, and that would generally be our best method of doing things. History, consider the mechanism of injury. What actually got him here? Was it exposure, entrapment, or immersion, etc.? Is it an at-risk population? Pediatrics, infants, immature nervous system, in children, large body, surface area to mass, and it's coupled with poor judgment. In the elderly, diminished subcutaneous fat, physiological capacities, and respiratory reserves. General health, hypothyroidism can predispose a patient to hypothermia, low thyroid hormone, low metabolism. Medications, drugs also can induce hypothermia. Diseases and conditions, endocrine disorders, make the patient more prone to hypothermia. On examination, level of hypothermia is determined by the core temperature. Most standard thermometers are dependent on peripheral locations, often the first affected by the vasoconstriction. Low core and tympanic membrane thermometers are available. Mild hypothermia, we get shivering, most notable physical finding with this. Hyperdynamic, tachypnea, tachycardia, and hypertension will be present. Loss of motor coordination, and then altered judgment. Special case of intoxication. Suspected intoxicated hypothermic patient, exercise caution. Threefold impact on hypothermia. Alcohol is a vasodilator, gives them a warm sensation. Alcohol depresses the shivering reflex, and it impairs the judgment. In assessment, hypothermia is a disorder divided into levels, mild, moderate, and severe. Also divided into compensated versus decompensated, and that's very simple. Does your body have the ability to compensate for this, or does it not? Model recognizes the importance of supporting the body's own mechanisms and the importance of intervention when the body is unable to compensate. In treatment, considerations should be made. Stabilize current temperature and remove all the wet clothing. Cover the patient. Remove from the environment, especially exposure to the wind. Passive rewarming. Patient's own heat is used to rewarm the patient. Wraps, shivering, etc. Eat for heat. Provide simple carbohydrates to support shivering. Active rewarming is adding heat to the body. In active rewarming, we always should watch for malignant hypothermia syndrome, which can lead to death. If cooled slow, warm them slow. Use passive rewarming. Methods for active rewarming: active external rewarming, chemical hot packs to areas where major veins rise to the surface of the skin. Hot packs warm up very fast, reaching temperatures of 160 degrees Fahrenheit, then cool down. Active internal warming, warm humidified oxygen, approximately 104 degrees to 113, administer either via mask or preferably via the endotracheal tube. Gradual hypothermic onset, special case of rewarming shock. Patients may experience cold diuresis, and this was from shunting towards the core and tons of fluid being diuresed off. Patient may experience cold diuresis. Vasoconstriction occurs, reverse when warming, and normal vascular space returns. The patient who is volume contracted will develop hypoperfusion. They can even lead to cardiac arrest whenever they're rewarmed. So be careful so that you can fill the container in case they have been cold diuresed. Preventing rewarming shock. If you use normal saline heated to 113 degrees Fahrenheit prophylactically, and avoid lactated ringers. Evaluation: any sign of a rhythm, withhold CPR. In hypothermic patients, they're very prone to ventricular fibrillation. Ensure that the patient is truly in cardiac arrest. Take a carotid pulse for at least a minute. CPR should commence, continued until the patient is delivered to the hospital or the rescuer is fatigued. Single defibrillation attempt may be ordered. Further attempts at defibrillation should be withheld until the patient is rewarmed. Disposition: the patient with hypothermia, transport to the hospital, capable of extracorporeal core rewarming. Warm saline irrigation of the lungs via bilateral thoracostomy tubes may be effective. Cases of multiple patients, options may be limited to this. Mild to moderate hypothermia, you can transfer that to pretty much any community hospital that can do passive rewarming. In conclusion, suspected hypothermia transports the patients for medical evaluation. Complications from hypothermia could be aspirin pneumonia, pulmonary edema, coagulopathies, and pancreatitis, and electrolyte disorders. Treat them appropriately, and they have a high survivability. Ignore and mistreat hypothermia, and it is very, very deadly.
If you have any questions concerning this topic, feel free to contact me. My name is Roy Smith, Smith at SamaritanEMSOK.com, or 405-492-8243. Thank you.